The management of acquired resistance to an EGFR inhibitor is always a complicated dialogue with a patient. I have one patient who's developing growth of a mass. The mass, in fact, is now bigger than it was in the beginning, but he's working. He wants to keep working. He doesn't want to keep traveling in for IV chemo, and he says, "Doc, can I hold it here for a little while?" And I say, "All right, I'm with you on that. We'll be vigilant. I trust that you're going to call me if something gets worse." He wants a clinical trial. He wants a biopsy. He's willing to risk it a little bit in order to get some other neat result down the line. And what happened was he got a biopsy. It found T790M. He's now on one of the new EGFR T790M inhibitors, and he's having a great response. And because he was comfortable working on this with me, holding off on chemo, looking for something different, we were able to get him to a neat drug. Another patient maybe isn't a good trial candidate, maybe has a recent malignancy and therefore is going to be excluded from trials, or has brain metastases. Another patient, we can't focus on trials so much and maybe is a little more nervous and doesn't want to play that risk. That patient, I'm very comfortable starting chemotherapy. It's standard of care to start the chemotherapy and say, look, we've got a real option right now that's commercially available. Use the commercially available option, start pemetrexed, and we'll save the experimental stuff for down the line. And so it comes to whether a patient's able to get a rebiopsy, willing to get a rebiopsy, willing to travel for a clinical trial, how much social support they have. All these questions come into the play as to whether we pull the trigger sooner or delay things and try to wait for later. Some people are trying to develop algorithms for this acquired resistance space to say, if this go this way, if this go this way, if this go this way. And I don't believe in that. It's not that simple to know we can go in this direction versus not. It's all a lot of clinical wisdom. And therefore, the way I see it is there's a stepwise series of questions. And we actually have a review article that's going to be published soon in the journal Cancer describing this sort of stepwise series where I first say, is the progression significant enough that we should change course? Okay. Next question, is the progression localized? And maybe we can get away with brain radiation and then going back on the drug. Next question, is the patient a good candidate for a rebiopsy to look for small cell, to look for T790M? Next question, is there a clinical trial available for this kind of patient, given that there's no clear standard of care based on good data? And after all that, we finally say, is it now time for chemotherapy? And if so, with erlotinib or without? And you should ask each of those questions for your patients, but it's very much a personal decision with the patient to decide at which point you continue further down or you stop and stay on the drug and save the next question for later. One controversial question is whether there's a role for surgery or radiation for a patient with locally progressive cancer. So let's say a single lung mass is growing back. They have stage 4 disease. They clearly have hidden metastases somewhere, but all you can see on scan is one mass growing. In that patient, should you do some radiation to try to sort of control that single spot in order to make us all feel better and then go about your way and get back on the erlotinib? My personal practice is not to use surgery or radiation routinely in those patients, because what I know is you can just hold your horses and they'll probably do fine. But that one mass, that is your opportunity for a biopsy. That's your opportunity for a clinical trial. And the fact is that irradiating all the stuff you can see might in fact limit your options down the line, cause side effects, make the patient sicker indeed by giving lung radiation without necessarily changing the course of their cancer. And so I will give radiation, use surgery for focal symptomatic disease that needs palliative therapy. But I don't hit these patients with aggressive local radiation just in the hopes of making the CAT scan look better and making us all feel better about their cancer.